Hello, everyone, and welcome to the Minnesota Actorly and Minnesota Follow Along Professional Development Series on autism and developmental delays. We are so happy to have you here for our June webinar. Yes, it is June. It's a beautiful June afternoon, and the peonies are blooming. So, welcome. We are so happy to have you. Next slide, please. All right, so before we get started with our content today, we just want to thank our sponsors of this webinar series. First is the Minnesota Act Early Project, and Krista is putting in website links to the Minnesota Act Early Project. Nationally, it's the Learn the Signs Act Early Project, and if you click on those links, we will connect you with a lot of wonderful free materials on early identification of developmental delays. Our other sponsors are the Minnesota Department of Health Follow Along Program and the Minnesota Autism Resource Portal. Thank you to our sponsors. Next slide, please. So the goal of this webinar series, and we've talked about it each time, and I realize I forgot to say my name. I am Dr. Jennifer Hall-Leody. I am at the University of Minnesota campus. I am a psychologist and a researcher in the field of early identification. And one of the sponsors of this series, we work to support early developmental monitoring and promote early developmental screening. We know the earlier we identify children and get them access to services and supports, the better their life outcomes. We also talk about in each series recognizing early signs of autism and how to support families. And one of our primary goals today is to connect you to resources that will help you in your work with young children. Next slide. So we're here typically the first Monday of the month, which that's what it is today. Again, welcome. Can't believe we're in June already. This is our fourth session in the series. However, next month, it actually, due to the 4th of July holiday, will be July 8th. So it actually will be the second Monday of the month next month. But today we're talking about mental health supports. Next month, overcoming common barriers and wait lists. And August 5th, our EIDBI and healthcare coverage. Next slide, please. Just a few housekeeping tips. We're in Zoom webinar form. There's a lot of you here, so we had to do a webinar platform. You're in listen only mode, but you are welcome to participate via our Q&A button at the bottom of your screen. If you take a look at it as a question mark above it on mine, you can click on that and put a question in there, and we will see our hosts are monitoring that, and we'll look for your questions and your participation. And then resources that we talk about will be sent out right after the webinar. Next slide. So quickly, our agenda today, we're talking about mental health supports and autism, doing a quick introduction, what I'm doing now, and trying to be quick so we can have time for our content. We'll then have a presentation from 2:10 to 2:30. We'll then share a family story where we apply our learning, what we talk about, a discussion. And again, we will welcome your questions and comments during that time, and then we will wrap up. So it's a quick hour, but we'll pack a lot into it. And I promise it will be interesting and compelling and provide you with plenty of resources. Next slide. So our speakers today, we are so lucky to have Dr. Catherine Wright here. Catherine is a licensed psychologist and professional clinical counselor. She's a former 0 to 3 fellow. She has over 30 years of experience providing direct children's mental health and understands children's mental health programs and systems. Um, as the state of Minnesota, she's responsible for developing early childhood mental health systems of care, which include arranging for and managing trainings and evidence-based practices for early childhood mental health clinicians. There's a lot there. You're welcome to read her bio so much, but I want to make sure she has plenty of time. And then additionally, we are lucky to have our colleague, Pat Police, also a licensed psychologist with over 40 years of experience. We are so lucky today. So much experience, so much knowledge and wisdom. She has extensive assessment and clinical experience with children and families at Fraser, a nonprofit community mental health center in Minnesota. As Chief Clinical Officer, Pat has led the development of Fraser's robust clinical staff development program, research, clinical compliance, and integrated health relationships with community partners. In 2013, she was recognized with the Outstanding Service Award by Minnesota Association of Children's Mental Health. She also was honored to be chosen as a 0 to 3 expert faculty for training on DC 0 to 5 and has provided this training to over 2,000. Wow. Minnesota mental health clinicians working with young children for Department of Human Services since 2009. More recently, Pat has supported Fraser's medical director with the launch of psychiatric services and health screening and monitoring, adding nursing staff to support a culture of integrated healthcare. In addition to her work at Fraser, Pat volunteers time with Center for Inclusive Childcare as a board member. Wow, we are so fortunate today. Welcome, Catherine and Pat. We are really looking forward to this topic and all the wisdom and resources and content you have to share. So with that, I'm going to turn it over to Catherine.
Thank you, and good afternoon, everybody. It's very exciting to be here today. And so Pat and I are going to talk a bit about what we are doing from a state perspective on supporting children and families and children who have been identified as being on the autism spectrum. So if we could go to the next slide. I always like to start off a public presentation with doing a land acknowledgement. This is one that a colleague of mine who works with me at the Department of Human Services and I developed with some consult from one of our colleagues who is Anishinaabe. So I will read it aloud. We acknowledge the stolen land on which we work and live, the land of the Dakota and Anishinaabe peoples. We recognize that contextual and historical factors impact the mental health of young children and families, and we acknowledge that historical trauma continues to be felt by Native American families and other communities who have experienced oppression and discrimination on these lands. We honor this land and the Anishinaabe value that every child is sacred by committing to supporting the health and well-being of our young children, their families, and those who support them through our infant and early childhood mental health services. Could go to the next slide. So part of what we were thinking about presenting to you all is really understanding the policies surrounding the assessment and treatment of young children in Minnesota, specifically understanding the processes that we use when we're doing diagnostic assessments in the mental health field of young children. And when I say young children, I mean children under the age of 6. And then really have a bit more of a conversation about understanding what we are doing specifically for children who are presenting as if they're on the autism spectrum. And I say that because oftentimes we are the first mental health people to see children when they are presenting with autism. And part of what we really want to think about is how to engage our community partners in this work with us. When we think about early childhood mental health, we always say it is everybody's business. And so to make sure that we are partnering as a team so we don't have families feeling like they have to retell their story 10,000 times. That can be often stressful for families. And then I'm going to talk a bit about the Medicaid service array, which is what we manage at the Department of Human Services. It may be different than what families on commercial insurance can obtain. And so I'll talk a little bit about that. And then we'll have our case example with some discussion. I want to go to the next slide. So the first thing I always like to clarify is that when we assess young children, when mental health professionals assess young children, we, in Minnesota, it is actually in our state statutes that we are using what is called the DC 0 to 5. And what I really love about this is that it was designed with a developmental lens. It assumes that parents or caregivers are the most important people for their children. And so they are a partner in this process. It also has high value around the importance of culture and really understanding that culture can be healing, not just racial and ethnic culture, but also spiritual culture and the culture of the family. And so really honoring that and gathering that information. It always assumes that we're using a multidisciplinary team, that the mental health professional is not sufficient to gather all of the information about the child, and really wanting to make sure that we are connecting with primary care or medical professionals. And if that child has ever come in contact with the school district or childcare, that we, with parent permission, are gathering information from them as well. And then the other pieces of it that are very important is that making sure that we understand development. And so oftentimes we are asking our clinicians to use standardized tools to gather information about cognitive development, but if there's testing done, we value getting that information and always wanting to understand the child's sensory needs. We know young children often present with sensory needs, and we want to better understand that to see how we can better support them. And I
And
often do,
Catherine,
oh yeah,
Catherine, if I can jump in, I think
please.
one of the things that we often talk about is how behaviors of concern are cross-cutting. So crying, dysregulation, you're talking about the sensory pieces, it might even be repetitive behavior. They can have a foundation in a whole host of diagnoses across the manual. So it's really important for clinicians to know about multiple diagnostic categories in order to rule in as well as rule out.
Thank you, Pat. We'll talk more and more about how, as clinicians, we want to make sure that we're gathering all the information so that we identify specifically what may or may not be getting in the child's way, so that we can help the family access appropriate services, and not just access services, but make sure that there's services that actually meet the child's needs. And then the final thing I'll just say is that we have offered this training for free for clinicians, mental health professionals, since 2004. And over the past almost 20 years, we have trained over 3,500 clinicians in this work. And Pat is one of our longest standing trainers that we've had, and we've been very fortunate to be on this journey with Pat for a very long time, and continue to very much value training new clinicians so that they understand how to assess appropriately young children, which is a very different process than assessing older children or adults. We want to go to the next slide. So just a little bit about the assessment process for young children. When we're using the DC 0 to 5, it usually involves at least 3 sessions. And the reason that it takes so long is we want to make sure we get it right, and we have to get all of the information. So usually, oftentimes, clinicians may meet with the caregiver alone first to get more of the history. And again, as I said earlier, caregivers or parents are assumed to be the most important people for their young children. And so really understanding their perspective about what they're seeing and what they're stressed about. Usually in the second session, we may do an observation of the parent and the child together. We often want to see, what is that relationship like? And where is it really supportive, and where might there need to be a little bit more support? And then if we can, we'd love to do a third session where we can observe the child either in a childcare setting if they're with another group of children, or what it's like for them at home. And I will say, since the pandemic, so many things have changed for us, but I will say accessibility has been increased. So a lot of these sessions can occur over a virtual platform, meaning that caregivers don't have to bring their children in every single time. And so at least from Medicaid, we can do a lot of these sessions via like telehealth. And that's a really lovely way for a clinician to see how the child is doing at home as well, because they can beam in as opposed to having to do a home visit or meeting with the caregiver alone. They can actually meet with the caregiver via telehealth, which has been very helpful. And then if there is a psychologist that's doing the assessment, usually testing can be a part of the process. And we highly encourage psychologists to also use this process when they're assessing young children. And I'll talk a little bit more about some of the efforts that the state has taken. If it is not a psychologist doing the assessment, we really encourage our clinicians to partner with others such as early childhood special education, or getting records from occupational therapists or speech and language therapists to help better assess the child's overall development. I don't know, Pat, if you wanted to say anything else about that. No. Okay. So what does a diagnosis look like for a little one? We, in using the DC 0 to 5, still have 5 axes. So if you're familiar with what the old DSM used to be, there were 5, and then they moved it down to 1. We still use 5 axes for the DC 0 to 5. The first axis is much like the DSM, which it's the clinical criteria. Does the child meet clinical criteria for a particular diagnosis? Axis 2 is different in that it's really looking at the parent-child relationship and also the caregiving system. So I want to be clear, it's not assessing parenting. It's really looking at what the child is bringing to the relationship and what the caregiver is bringing, and also what the overall system is supporting or not supporting the child and the family system. Axis 3 is about medical related issues. And what we encourage our clinicians is that always get medical records with parent permission. We often find, and I'll just say this as a practicing psychologist, which I do work one day a week in the community doing psychological evaluations, we find secret information in there that maybe the caregiver didn't know, such as I've had a couple of children that tested positive for high levels of lead. And high levels of lead will can absolutely impact one's cognitive development. So if we're finding those things, we want to make sure that that child is getting, 1, reassessed for lead poisoning, and 2, treated for that. We've also found children that have hearing loss, where the caregiver may or may not have known about that. And I'll talk a little bit more about this with autism in particular, but if a child cannot hear, they oftentimes don't respond to their name or don't make great eye contact when people are talking with them. And so we want to make sure that we understand how are their vision and hearing working. And also primary care gives us just a ton more information about are there other things that have popped up that maybe didn't get identified or addressed. Axis 4, we're attending to, are there stressors in the child's life that have happened? And I will say some of the more common ones that we've been seeing over the past few years is certainly COVID. But some others that often happen for our youngest children are foster care placement. Children under the age of 3 are the largest group of children that are placed in foster care in this state and across the nation. Other stressors could include any kind of other traumatic experiences. It could include multiple moves. It could include the loss of a very dear family member, like a grandparent. So those are the things that we're asking caregivers about. And then Axis 5 is a very important one, and it's looking at development across the 5 major areas of development for young children. And I'll just call them out so you know what they are, but we're looking at emotional and behavioral development. We're looking at social relational development. How do they engage with other people? We're looking at motor development, and that includes both fine motor, ones like work with their fingers, and then also gross motor, kind of big muscles. It's also looking at speech and language development, and then cognitive development. And what we often want to have happen is we don't want people to, I'll say, eyeball development. We know that from research that doesn't work. We miss kids 80% of the time that need further assessment when we're just looking at them. So we want to use standardized tools. Pat, did you have something to say about that?
Yeah, I just want to add that this framework is really helpful in thinking about what are all the things we really need to collect in a thorough assessment. And then consistent with the objectives of this webinar series, the developmental piece. How does it look in early development when there's conflict in the relationship or there's stressors like homelessness? How does it appear in a child that's 18 months versus 4 years? And these are things that we talk about in our monthly case reviews with those 3,000 clinicians that have been trained. They can attend monthly case reviews to talk about cases so we can all hone our skills and increase our knowledge.
Thank you, Pat. And I will say, we are big advocates. If testing has occurred, say by a school district, we do not want to do retesting. We'd actually like to take the school district's testing results and add them to the assessment. And I will say that what really matters, and I'm going to talk more about this in a minute, is actually the test scores. The test scores will help families access a plethora of services, as opposed to just saying that the child has a delay. We actually need specific test scores to see if children will qualify for other supports and families will qualify. So I did want to say that out loud. But one of the things that we've been promoting, certainly if there's testing already existing, to incorporate that. If it is a psychologist doing the assessment, please do testing if it hasn't been done. And then if there isn't a psychologist or testing hasn't been done, we are recommending to our professionals that are doing these assessments to use a standardized screening tool. And the one that seems to cover all bases for us at this point is the ASQ. And so those are things that we are highly recommending for our professionals doing these diagnostic assessments. We don't want to eyeball kids. We want to actually use tools that have been developed to better at least screen for developmental related issues. And I will say, and I know you've heard this before, screening will not tell anybody that there's a delay. They will tell somebody that there are concerns and that they should be further assessed. We can go to the next. So part of what we do in our training of our clinicians is we want to make sure that we are not pathologizing cultural norms. And we all come with culture, and we all come with ways that we understand the world. Our ways are not necessarily the same ways that other people have been raised. And so some of the things that we want to pay attention to is eye contact. In many cultures, lack of eye contact is not an indication of autism. It is an indication of respect. You don't make eye contact with elders without permission. And so we would ask a caregiver, if they say my child isn't making eye contact, the big question is that a concern for you? What does that mean in your culture? Some other things that we've learned from our partners is like co-sleeping is very common in some American Indian or Native American communities. And then some of our communities really believe in the presence of ghosts or spirits and are not an indication of hallucinations. So really asking if there are symptoms that our caregivers are bringing up, asking what does that mean for you in your culture? Is that a concern? And really holding caregivers as utmost important in helping us think about those things. And I will say it is a tricky practice, especially when we have children in foster care who are not living within their communities. And I do want to say that out loud. So we have really been trying to also help our clinicians get connected with more cultural liaisons so they can ask questions of the community as well, and not just the person who may or may not be of the child's culture. I want to go to the next one. So when we do our assessments of young children, we want to look at the axes 2 through 5 first. And one of the things that we've been really trying to support our clinicians in understanding, and I think Pat said this earlier, and we could talk about it for days, but a lot of times medical issues look like mental health issues, but they're not. So a big one that comes up for us all the time is a lot of our children in Minnesota are asthmatic. And when they're on asthma medications like an albuterol, a side effect of albuterol is hyperactivity. And so we always say this child needs albuterol to live, and they do not have ADHD. And so we need to be very thoughtful about that and make sure that we better understand what are the medical issues that the child is presenting with. Are they being treated? And does the medication have a side effect that might look like a mental health related issue, but is just a side effect of the medication? Another one that comes up a lot for us are hearing issues. A lot of our children get ear infections pretty regularly. So one of the common questions we often ask is, does your child have a history of ear infections? If the caregiver says, yes, they do, have they ever had tubes placed where they are getting their hearing checked and making sure that and then have they had a hearing test? And as a psychologist, oftentimes if the child hasn't had their hearing test and the caregiver has worries about autism, I'll say, let's get their hearing test first. because I want to make sure that I am not understanding something that it's not. And I'll give you an example. I had a little one years ago where the family did not speak English as a first language, and the child presented with some autism symptoms. However, I found deep buried in a medical record that the child might have had hearing loss. I actually asked the school district, can you retest his hearing? Because they were going through early childhood screening at the school district. And the district emailed me back or called me back and said, actually, Catherine, he is partially deaf. Okay, let's get that addressed first before we go on with further testing. And that would make some sense for us. So it's so very important that we continue to think about it. And then we also know that a lot of medical issues might have long-term developmental implications. And I will say, over the years, we've really encouraged our clinicians to help to advocate for families to get those medical issues addressed if they haven't been addressed, because they could have long-term impacts on how the child will develop in the future. And one of the big ones that has been coming up more and more for us is we're learning that a lot of times children with vision issues, not the vision issues that you can test very readily at the doctor's office with putting your hand over your eye, but other kinds of visual processing issues look like ADHD, and they're not. They're visual issues that need a developmental optometrist to actually address them. So again, kind of thinking about how do we learn from our medical records, and then how do we better support caregivers in getting the correct assessment so they can start to take care of some of those medical related issues.
I just want to really quickly say that as we are talking about autism, a good amount of research suggests there are co-occurring medical conditions as these children age. So we do want to be screening these pieces and working closely with the primary care provider in order to address these. All of you on probably are thinking about sleep, eating, gastrointestinal issues. These are things that commonly pop up, and we should be addressing. Sometimes they are the focus of intervention.
I guess that, yes, that's so complicated because oftentimes children, it's not an or, it's an and. And so we need to hold both about how do we make sure that we're coordinating care with primary care. If you can go to the next slide, please. So this is some of the things that I was saying, that sometimes lack of eye contact or language development may be an indication of hearing issues. So let's make sure that we're assessing for those. Many vision issues may look like attention deficit disorders. Those, I will be honest, are harder to test when kids are under the age of 6. Usually developmental optometrists do. They start to pick it up a little bit better when children are starting to learn to read. So usually around 7 or 8 is when they're able to assess it better, but it is absolutely something to hold and for us to think about. And then we know that fine motor delays can absolutely impact a child's overall development, and also their ability and frustration potentially with doing fine motor work, like holding a pencil. So one of the things that I often say as a psychologist that's testing a lot of young children is we use ink daubers, like those big bingo daubers, because then we're not having confounds for fine motor related issues that might not tell us about a child's speed in something, but more tell us that they haven't quite been able to manipulate with fine motor related developmental skills. I want to go on to the next one. And then we're also really attending to access for stressors that children have encountered. And one of the things that we as a state have really wanted to do is to really make sure that we're ruling out trauma first, because historically we know that trauma often gets missed. And what we tend to see is a lot of behavior, but not understanding where the behavior comes from. And so we know that young children who have experienced a great deal of trauma, I've been assessing children for a very long time, they may not speak. One of the first things that tends to be lost is language, or they may not make great eye contact, or they might be super triggered by touch, like sensory things might be really difficult for them. And so we're really trying to better understand what is the history that they've experienced so we can better support them. And then we do know that early trauma and neglect can delay cognitive functioning and language development. And so sometimes we need to, well, oftentimes we need to certainly address the trauma, make sure that it is stopped, or put some supports in for the caregivers to decrease trauma, and then start to address some of those other issues. And it does get really tricky, I think, when children present with both autism symptoms and a trauma history, and that is not unusual. And so thinking about how do we address both is something that we're working on constantly as a clinical system. I want to go to the next one. And then for Axis 5, this is again the developmental axis that we always pay attention to. What we've really tried to better support our clinicians in is use standardized tools. So one of the tools that we've consistently talked to our providers about is using the child behavior checklist. It is a social emotional tool. It's an assessment tool, and it's filled out by caregivers and teachers. So if you are a teacher and you get asked to fill one out, please fill it out, because we need your information to better support us in the assessment. And then it also has a caregiver form. And what we found from our colleagues at Fraser, who do way more testing than many of us do, is that when the autism scale is elevated with a withdrawn scale, those are two scales on that particular assessment, we want to have that child assessed for autism. We're finding that more consistently, that those, when caregivers are picking out those kinds of symptoms, that those are children who are probably actually qualifying for an autism diagnosis and should be further assessed. And then the final thing I want to say, again, going back to culture, we historically and continue to have a lot of issues in this state where children, and in the nation where children of color have been misdiagnosed, and people are not understanding the behaviors that they've seen, and they have oftentimes misdiagnosed children with oppositional related behaviors or conduct problems when they really had autism. So we're also really trying to better support all children, but especially children of color who have unfortunately experienced a lot of oppression in many of our systems, to making sure that we are doing right by them in understanding their symptoms from a developmental lens and a cultural lens, so that they're not getting misdiagnosed and getting inappropriate treatments. Pat, did you have anything else you wanted to say about this?
As you've gone through Axis 3, 4, and 5, I just want to remind everybody that you can have multiple things on something on every axis. In fact, you could have a genetic disorder, you could have a condition on Axis 3, but as Catherine starts to get to Axis 2 and 1, we're really looking at a constellation of behaviors. She's already described this. So we're not looking at cause in most cases, especially when we're looking at autism. There is not a known cause. So we are looking at these constellation of behaviors rather than thinking about a specific cause. So you could have something on Axis 3, a condition, as well as something on another axis.
Thank you. If you could go to the next slide. So I want to tell you a little bit more about why testing is so very important for families. One, formal testing can clarify the diagnosis, but for children who do qualify for an autism diagnosis through the DC 0 to 5, it also helps the family access a number of other services through the county. And so one of the things that it could help support the child in getting potentially services through the developmental delay units at the various counties. It can also help children who are on commercial insurance qualify for Medicaid, which the Medicaid benefit set offers families quite a bit of flexibility and additional resources. It can also help children qualify under the state medical review team eligibility, and scores matter. And part of the things that we've been learning is that some of the basic tests, and I forgot to include one here, but an ADOS is kind of the gold standard for testing for autism. cognitive testing. And I put a list of the cognitive tests that counties accept for children ages 3 to up to 21. And then an adaptive test, that's the one I forgot to include. Oh, it's there, adaptive testing, to see like how is the child functioning in their system. And so if you are a school person who's doing testing, we really, and we want to include your information. So just a school assessment doesn't oftentimes just automatically qualify a child for additional services. Oftentimes a mental health professional will have to take that and add more information, but testing scores do matter. And especially if you're using any of these particular assessments. And as a psychologist, I just really hate to put families through a whole nother testing battery if they just had one done. Similarly, as a psychologist, if I'm doing testing and I know the school district's in the process of doing testing, if I can get it done right away and just hand them the report and then they can fill in the other pieces that they need, I would rather do that with parent permission. Again, not putting a family through the same battery of tests twice. That just feels very unsupportive of families and certainly stressful for children. I don't know, Pat, if you had anything else you wanted to say about that. All right, next one. So just a couple of things just to know about the DC 0 to 5. There's actually 3 diagnoses that fit under the autism umbrella. There's the early atypical autism spectrum disorder. It actually goes ages 9 months to 36 months. It requires less symptoms than an autism diagnosis, and it automatically qualifies children under the DC 0 to 5. We have the autism spectrum disorder, which is usually ages 18 months and older. And then there's this other neurodevelopmental disorder of infancy and early childhood. And what we often encourage our clinicians to do is, if they aren't able to do testing or no testing has been done yet and they're not doing testing, to give that until we can get that child further tested to make sure that we know that it is actually autism with those specific assessments that I talked about earlier. And then the diagnosis could be changed with either that clinician or potentially the psychologist doing the testing. I don't know, Pat, if you had anything else to say about these. Yeah. Okay. We want to go to the next slide. Just a couple other things in case you didn't know. So if a child is under the age of 3, most of our DC 0 to 5 diagnoses automatically qualify them for Part C, or what we call in Minnesota early intervention. So just a heads up for you about that. And then if the children are ages 3 to 5, most of the diagnoses from the DC 0 to 5 usually qualify for one area, and for Part B 619 or early childhood special education. And we know that we need 2 areas of concern to usually qualify for those services through the school district. So oftentimes school districts are taking the assessments that a clinician is doing and incorporating that into their special education assessment, which I think is super helpful. Again, the more we can partner as team members, the better off families are, and then the more supportive services that can be developed for young children. So after we do this assessment, then we have kind of a holistic conceptualization with the family about developing an appropriate treatment plan or recommendations. And that's always done in partnership with the family. I should say one super unique thing to Minnesota, it's not common across the nation, but in Minnesota, autism qualifies as a mental health diagnosis. In some other states, it does not. It is only a developmental delay diagnosis. It is not a mental health diagnosis, why does that matter? Because from an insurance perspective, families can access mental health care with a mental health diagnosis. So that's why it matters. So in Minnesota, it does qualify. You want to go to the next slide. So we have this very complicated continuum of services, with outpatient psychotherapy kind of being on the end over here, and more intensive services such as a psychiatric residential treatment facility or hospitals on the right. And I will say, many of our young children don't necessarily qualify for very, very intensive services, but I will talk a little bit about some of the service array that a lot of our children who are under the age of 6 may qualify for if they qualify for the diagnosis of autism. You want to go to the next slide. So one of the things that we have been finding over the years is autism oftentimes in mental health is considered a specialty that requires some specialized training. And what we're finding in some of our areas in what I call greater Minnesota or outside of the Twin Cities, we don't necessarily have a lot of mental health supports for children on the autism spectrum. One of the interventions that is pretty commonly trained here in Minnesota is parent-child interaction therapy. I have that listed here. It is an intervention that actually supports caregivers. It trains caregivers on how to do both non-directive kinds of play therapy things, following their child's lead, reflecting back what the child says, delighting in their child, giving them big smiles, and then it also supports caregivers in being clear and consistent. So giving, if they want the caregiver to, if the caregiver wants a child to follow directions, how do you give a direction that's clear, simple, and then making sure you're consistent in your follow through if the child doesn't follow your directions. We've trained many clinicians in this intervention and many trainers. And so we are doing more and more training these days. And there's a lot more research these days on also how effective it is for children on the autism spectrum. It's been very helpful for children who are struggling with attention issues, who've had issues with anxiety, or just having a difficult time kind of following grown-up directions. And so this is super helpful. This intervention is very helpful for children who are qualifying for some support, but not needing intensive support. And I think we have a link there, so if you want to find a provider. The other thing, again, like I said, with COVID, it's now portable, so it can be done via telehealth. Basically, the clinician is not even in the room with the caregiver. They're coaching the parent through the intervention. And so it can be done on a screen with the caregiver. The child doesn't even know that the clinician is there. And they wouldn't even in the clinic. So it's kind of a lovely intervention that can be done across the state without having that caregiver having to drive far to get that service. If you want to go to the next slide. And then a more common service is children's therapeutic services and support. And this includes a combination of skills services that can be done directly toward the child or the caregivers. And it can be a service including outpatient psychotherapy. And in this area, it also includes preschool day treatment. And we have a number of day treatment programs. Day treatment is a group intervention with usually 8 children or less and at least 2 clinicians, sometimes up to 4. And it's a lovely opportunity for children to be able to practice social skills with other children in a therapeutic way. And so we have our list there of those CTSS. CTSS also includes home-based work where a skills worker can go into the home. And a lot of times our CTSS providers are also in the schools and more are serving preschool related programs. I don't know, Pat, if you had anything else to say no, okay. All right, and the next slide. And then there's some more specialized services. Children may qualify for mental health targeted case management. In Minnesota, autism actually could qualify a child for case management, for mental health case management. It does not qualify adults for targeted mental health case management. It is not one of the diagnoses that would qualify an adult. But in Minnesota, in the Medicaid benefit set, we are birth to 21. And so here's the criteria here. And one of the big questions is if this child doesn't get support, are their symptoms going to increase or are they going to have more stressors in functioning? And I think that could be said for many of the children who qualify for an autism diagnosis. We want to go to the next. And then the state has been approached recently by an agency that is interested in doing a partial hospitalization program, which is usually thought of as a little bit more intensive than a day treatment program. It's usually done in a hospital setting. And we know that in other states, a lot of those services are often really geared toward children diagnosed with autism. And so hopefully that that particular agency will get through the credentialing process soon, and then we'll hopefully have a more intensive service. And they're looking at doing it for young children specifically. We don't really have very many partial hospitalization programs that go down. I think they're interested in going down to 2. I think we have one that goes down to 4. Barely. So just thinking about how that could be super supportive for families if they need it. We want to go to the next slide.
All right.
Right.
The case study. Thank you, Catherine. So much good information. And we have so many resources in the chat, links. Wonderful. Just looking at time a little bit. One, you have many excellent questions. And Catherine, can you take a look at the Q&A and perhaps answer them via typing while Pat reads the case study so we can get some answers on those? And then Pat, are you able to do maybe a condensed version of the case study or get through it? And then we'll save a little time. But thank you again, Catherine. That was a wonderful presentation, just loaded with great resources. Pat, I will turn it over to you.
That sounds good. I was thinking the same thing, Jen. So I'm just going to set up, you see the case study on the screen. I encourage everybody to think about the framework Catherine has talked about, those 5 axes. In this case is a compilation of cases, including many of those things, and hopefully just points out the importance of collecting a broad range of information. So here you have a 15-month-old Jade who is presenting with concerns that could really set in a whole host of categories and receive different kinds of interventions. And like many of our kids, the referral maybe came from a child care provider and caregivers are following through. It's not uncommon for our families to have siblings. And you see in this case, Jade has a brother that's already been diagnosed and a sister who's engaging and hardworking, but also needs some additional support. Very common. You have a family where the conflict and disagreement, potentially on the depth of their concerns around diagnosis, has added to maybe some relationship challenges. So they live separately and have an arrangement, adding another layer. And then as we get down to the concerns that the caretaker, Jade's mom, Mari, reports, she's getting input from extended family, people in this child's life, to let her cry it out. They value independence. Catherine talked about culture. What are the family values? And sometimes they set a lens that can be stressful for caregivers that are already feeling incompetent to parent. And then you have a mom who is not wanting the child to go spend time in a separate household or outside because she rejects comfort, and mom is protective because Jade she's not really doing these things on purpose. And as we go to the next paragraph, you see a little bit about medical issues, Axis 3, talking about some things about hearing, about eating. A food tube has been suggested somewhere down the lane we need to look into, and then some language that's just emerging. So when we think about all the things that are impacted, lots of our kids talk about sleep, eating, and attention, all impacted by dysregulation. And in the end, like many caregivers, they're coming to the clinic because they want to figure out how to engage and enjoy their child so the child can grow up happy. We'll stop there.
Great summary, Pat. Thank you so much. Michelle, do you want to take us through the questions?
Yeah, let's go ahead to the next one. Hi, everyone. Michelle Quickstead here, Early Identification Intervention Planning Director for the Department of Health. So happy to have you here as co-host with my friend, Dr. John Hall-Landy. Great presentation about the mental health pieces. As you can see, and as you already know, it's complex. And so when we think about children with autism or who haven't been identified with autism or developmental delays, there's stressors that families go through. And so the family story that Pat just so wonderfully kind of summarized for us, we have some questions for you to think through. We have some great questions in the Q&A already that will go ahead, but go ahead and take a look at these questions. What are some initial steps to help this family? Catherine and Pat did a great job talking and setting the stage about what are some medical conditions or factors that we want to be thoughtful about when we're thinking about children's behavior and how to get them support. What are concerns in the child or family's relationship? What are some next steps for intervention? So the axes that Catherine went through really help us think about what are the factors or what are the considerations that we need to think about. But Catherine and Pat, there are some questions in the Q&A. I'd love to have you help us think through. One was early on when we were talking about clinicians screening ASQ3 and SE2. So many of our local public health providers use the Ages and Stages questionnaire to help them think through what are some concerns around screening related to autism and developmental delays, but the MCHAT was not addressed or talked about. Can you tell us a little bit about what the preferences or what your thoughts are about using Ages and Stages at any additional supports in screening children for autism?
I'll start, Catherine. Ages and Stages is one that we talk about with all of our clinicians that are not mental health or psychologist practitioners. But it's important to say that as you start to hone in what the symptoms and concerns are, there are multiple tools out there, including the MCHAT, that can be used to support some of the questions that we might have. So we start with this huge lens and start to narrow it down. And sometimes as you look at these axes, sometimes it's the medical pieces that the family is most concerned about. And those are the things that are going to provide the support first. And then we start down that list of other pieces on the axes. But certainly the MCHAT can be used, and information from other assessments, speech and language, occupational therapy, all really important contributions to the picture.
So there isn't any one tool that I'm hearing you say, Pat, that is a tool in going down that continuum of identifying concerns. So the ADOS or the MCHAT or the CBCL, do you have any in terms of a preference or what you think people should be using or have a preference about?
Can I say something about that? So the CBCL is an assessment tool. So a clinician should use the CBCL, not a primary care clinic. Like, that's not appropriate. A screening, again, and I love the ASQ because it covers more than autism. So we want to make sure that we're getting all areas of development and I like also the ASQSE in like a primary care setting because it also is collecting some of that social emotional related information that may not be picked up by the MCHAT because the MCHAT is so very, very specific. I will say our biggest referral source for autism is medical providers, because I do believe that they are doing what the American Academy of Pediatrics is suggesting and doing things like the MCHAT. And it's the one system that all caregivers pretty well go to. I think something like 95% of our families on Medicaid are being seen in primary care. So if you are in a primary care setting doing the MCHAT with an ASQ, I think is a lovely opportunity. You're covering it all then. Do not start to try to use an assessment tool. Use screenings, like have the assessors. That's what we're asking our assessors to use, the assessment tools.
Thank you. That's wonderful clarification. Really appreciate that. In what ways can the primary care clinic assist more in efficient coordination of testing, diagnostic activities or connection with services?
Primary care clinics are essential. Catherine's really emphasized the use of medical records. Many of our families, that's where they first bring their concerns. And so as a trusted partner, we definitely need to leverage that team and both be working to, the common good for the child and make sure we're hearing what the family is most concerned about. So that connection is definitely important.
And can I just say what would be so easy? If primary care knows that a child is going to be assessed by a clinic, get that family to sign a release of information from that primary care physician immediately and send the records to that agency. Because that's one of the things we hear often from our clinical providers is they're not getting medical records in a timely manner. And I didn't talk about this, but I should have. For families who don't speak English as a first language, couple things I'll say is that they have a harder time signing releases unless they're meeting in person with clinicians. So getting them electronically is really difficult. If they're going into primary care, getting releases makes such great sense, and helping to facilitate that process is super important. The other thing I wanted to say about that is somebody who does do assessments with young children where the family doesn't speak English as a first language, we still need scores to help those children qualify for services. And so often many psychologists will put, we know that this test was done with an interpreter. It may not be done in the standardized way. We usually put a statement there just so that we're honoring that, yes, the test was not developed in this particular language, nor does the clinician speak it. But we want to make sure that that family can access all the resources that they can. And I've had cases come back to me where they said we need the scores, otherwise we can't give the family the services. And so I just wanted to say that out loud as well.
I think that's so critical, Catherine. When we think about how to support families, one of the ways that we can help support them as providers is making sure they get the evaluations and the assessments they need to qualify for county and state supports and services. And without those scores, whether you're a practitioner, if you're in the school district, those scores are so important. And we've been told that many of our tools are not normed within the culture of their language. And so the scores aren't valid. But I think Catherine gives us all a really great tip and trick to make sure that absolutely we should be writing down those scores, but we should be making a note in terms of the language or the cultural pieces that have been talked about in our presentation today. Dr. Jen Hall-Landy, would you add anything else to that?
No, absolutely. I think that's important advice. Additionally, I'm looking at time and we have 4 minutes left. There's just so much. We should have done 2 hours. Maybe we'll do another session on this. I'm going to bring us back to closing us out. Catherine, though, and Pat, it looks like there's just a lot of good dialogue here. Would you be able to put your emails, if you're okay with that, in the chat so people can reach out if they have more questions about autism and mental health services? Additionally, thank you for getting through the questions. We had a lot of good ones, so appreciate you typing those in. Next steps, please watch your email, complete the survey. We would love feedback as well as, and we have been loving seeing the resources you use in these spaces so that we can share your wisdom, knowledge, and expertise with the broader group. So please, thank you for completing those. You will also receive a certificate as well as a resource sheet with a lot of the resources that were shared today, as well as just summaries of some of the key points. So please fill that out. It's helpful to us and it's helpful to you, and you'll get some great things in return. Next slide, please. So again, we hope to see all of you and your friends, and feel free to invite your family, friends, neighbors to our July 8th session, Overcoming Common Barriers in the Autism Space and Wait Lists. Many of you had questions related to the long wait lists. We're going to talk about that next month. Again, it's not the first Monday like we usually do. We've moved it to the 2nd. So see you July 8th, mark your calendars. And then after that, August 5th, we'll be talking about healthcare coverage and Medicaid benefits. So we look forward to seeing all of you. Next slide. And there we go. Thank you. Thank you everyone for attending today. Thank you for your participation, your questions. Thank you, Pat and Catherine, just a wealth of great information. Thank you to my colleagues for running this smoothly, and we look forward to seeing everyone in a little over a month for our next session. Thanks, and have a great rest of your day.